Hello, student doctors. This is a pharmacology lecture called Drugs for Thyroid Disorders. My name is Jeff. Let's get started. There are two evidence-based medicine links. Click on the link. Why propranolol is preferred to other beta blockers in thyrotoxicosis or thyroid storm. Click on the other link. The mechanism for amiodarone-induced hyperthyroidism and clinical implications. Two amazing resources that'll help you work your way through this material. Also very good for board prep. Here is a Mayo Clinic Thyroid Storm case study. Click on the link, Thyroid Storm case from the Endocrine Teaching Clinics. This case study will also help you work your way through this material and serve as additional board prep. A 33-year-old woman presented to an outside facility with increasing shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, and increasing lower limb edema. These are all findings suggestive of biventricular heart failure. Further questioning revealed a 2 to 3 month history of unintentional weight loss, heat intolerance, diarrhea, abdominal pain, and palpitations. The symptoms started 6 months after her most recent delivery of a healthy child. Her past medical history was significant for obesity, mild asthma requiring occasional albuterol, and a third trimester gestational hypertension during her recent pregnancy. This was managed without pharmacotherapy. On presentation, the patient showed signs of tachycardia at 118 beats per minute and tachypnea at 22 breaths per minute and had lower extremity pitting edema. Lab testing was significant for hyperthyroidism. TSH less than 0.1, normal is shown here. Free thyroxine of 2.6, so TSH was low and free thyroxine was high. The serum brain natriuretic peptide was markedly increased at 2,819 picograms per mil. Here's normal, is less than 100. Chest x-ray demonstrated cardiomegaly, enlarged heart. Patient was diuresed and started on beta-adrenergic blockade, Propranolol, and 10 mg of Methimazole 3 times a day. An echocardiogram demonstrated a severely dilated left ventricle and an ejection fraction of 10 to 15%. Despite treatment, shortness of breath and hypotension necessitated intra-aortic balloon pump placement and intubation, and she was transferred to Mayo Clinic in Rochester, Minnesota. The endocrinology department was consulted. Mild exophthalmos was noted without dermopathy or acropathy. The patient's presentation with decompensated heart failure preceding GI complaints and tachycardia was highly suggestive of thyroid storm, Birch and Wartofsky point scale. Aggressive therapy was started with 200 mg of PTU, Propothiouracil, administered every 4 hours, 100 mg of hydrocortisone, administered every 8 hours, and saturated solution of potassium iodide, administered 2 hours after PTU or Propylthiouracil. Repeated biochemical testing revealed TSH of less than 0.01, so absolutely no TSH. Free T4 of 3.4, very high. Total triiodothyronine of 308, also high. Exophthalmos, also called exophthalmus, exophthalmia, proptosis, or exorbitism. It's a bulging of the eye anteriorly out of the orbit, bilateral as seen in Graves, or unilateral as seen in orbital tumors. Thyroid dermopathy, also known as pretibial myxedema, presents as non-pitting edema or plaque-like lesions on the pretibial. Thyroid acropathy is seen in cases of severe thyroid dermopathy characterized by soft tissue swelling and clubbing of fingers and toes, as well as periosteal reaction of the bones and hands and feet. Early recognition and appropriate treatment of thyroid storm, which may even include thyroidectomy, is essential to improve health outcomes. Thyroidectomy should be pursued when medical therapy fails to control the thyrotoxicosis. Extracorporeal membrane oxygenation, ECMO, should be considered as a means of cardiac support in patients who are unresponsive to conventional therapy until thyroid hormone normalization can be achieved. Would encourage you to dig a little deeper in that Mayo Clinic case study to get a deeper understanding of drugs for thyroid disorders. And this particular case study, which is sort of emblematic of how things can go wrong in the series of events in treating thyroid disorder. See, here is the aorta. Here's the right subclavian artery, common carotid artery. Here's the right lateral lobe and the isthmus of the thyroid gland. Here's the left lateral lobe. Here are your learning objectives and some recommended reading from Katzung. Describe the basic physiology of the thyroid gland, including iodide metabolism and hormone synthesis, transport, and hormone metabolism. We're going to compare and contrast the basic and clinical pharmacology of thyroid and antithyroid drugs, paying close attention to to levothyroxine, thioamides, and iodine. Thyroid agents include levothyroxine, T4, desiccated thyroid glands. Anti-thyroid agents include I-131, radioactive sodium iodine, methimazole, potassium iodide, and Propothiouracil, also known as PTU. List and describe drugs known to affect thyroid function and thyroid and antithyroid drug, typical drug interactions. We're going to compare and contrast the different clinical situations that necessitate treatment with thyroid and antithyroid drugs, including hypothyroidism and hyperthyroidism, such as occurs during Graves' disease and thyroid storm. Again, some recommended reading from Katzung. Humans have 48 nuclear receptor superfamily members with a conserved overall structure. Here's the N-terminus of the protein and the C-terminus of the protein. There's a central DNA binding domain and a C-terminal ligand binding domain. Each are surrounded by activation functions. These are DNA binding proteins that activate transcription. So AF1 stands for activation function number 1. AF2 is activation function number 2. And ligand stands for that domain of the protein that binds to ligand. So in our case, it's where thyroid hormone binds to the thyroid hormone receptor through the ligand binding domain. The classical nuclear receptor superfamily members are shown here: glucocorticoid receptor, mineralocorticoid receptor, progesterone receptor, androgen receptor, estrogen receptor, and we're going to talk about the thyroid hormone receptor. Note there are two flavors, alpha and beta. Virtually everything we're talking about today functions through thyroid hormone receptor alpha. There are adopted orphan receptors that belong to this superfamily member. There are also classic orphan receptors that have no known ligand associated with them. All nuclear receptor signaling occurs in the following manner. A small lipophilic ligand, such as thyroid hormone, shown here as a gold diamond, binds to its cognate receptor. Here, imagine the thyroid receptor is in red, binding to the thyroid hormone in gold. Complex shifts conformation and binds to its target sequences in the nucleus where that receptor is expressed. Estrogen receptors are expressed in breast and uterus tissue, ovaries, for example. But they all bind to their target sequence in the nucleus to regulate target gene expression. Some of the more familiar hormones are shown here. Again, we're talking about thyroid hormone binding the thyroid hormone receptor to regulate thyroid hormone responsive genes in the thyroid gland. Thyroid hormone receptor binds to DNA as a heterodimer with retinoid X receptor in association with histone deacetylases that recruit nuclear receptor co-repressor or silencing mediator of retinoid and thyroid hormone transcription. These histone deacetylase multiprotein complexes are associated with chromatin in the absence of hormone. When you add hormone like levothyroxine, NCOR and SMERT HDACs dissociate, whereas coactivators and histone acetyltransferases associate, and you get gene activation. This is how thyroid hormone works. Thyrotropin releasing hormone, TRH for short, is released from the hypothalamus in response to low levels of thyroid hormones. TRH stimulates the anterior pituitary gland to produce TSH, thyroid stimulating hormone. TSH stimulates the thyroid gland to produce thyroid hormones. The increased production of T3 and T4 increases metabolism, growth and development, and regulates catecholamine effects. Shown here are the different forms of thyroid hormone produced by the thyroid gland, to include T4, the structure of which is shown here, T3, which has 3 iodines in a stereospecific manner, and reverse T3. Now, T4 is often thought of as a storage form. High levels of T4 can be found in serum and are converted to the active form of the hormone T3. The role of reverse T3, which is totally inactive towards the thyroid hormone receptor, is not quite clear. Here is a drug list of thyroid agents, including T4, T3, Leotrix, a 4-to-1 ratio, T4 to T3, and desiccated thyroid glands. There are anti-thyroid agents, I-131, potassium iodide, methimazole, and PTU. And they can be classified as treatments for hypothyroidism, so you just replace the hormones, or hyperthyroidism, in which you decrease production of the hormones. Let's talk about the biosynthesis of thyroid hormones. Let's use this chart on the right. Here are the symbols: I-, iodide, I', iodine, MIT is monoiodotyrosine, DIT, diiodotyrosine, thiocyanate, and perchlorate. It starts with the iodide uptake transporter protein, which takes iodide into the cell, and through the actions of an enzyme called thyroperoxidase produces iodine, which is oxygenated iodide. Thyroglobulin is the matrix protein upon which monoiodothyronine, diiodothyronine, T3, and T4 are synthesized. Inside the thyroid gland, there's a proteolytic reaction that releases free T4 and T3 into the blood. And in the peripheral tissues, T4 and T3 are used. T4 specifically is converted to T3. It turns out in the peripheral tissues, T4 and T3 both bind to the thyroid hormone receptor. However, T3 binds approximately 40 times higher affinity than T4. They both can bind and activate, but T3 is 30 to 40 times better activator of thyroid hormone receptor than T4. It's for this reason that T4 is thought of as the reserve form of active T3. Moreover, T4 is usually in higher concentrations than T3, and it's converted at the site of action when and where it's needed. So you might be wondering, what do thiocyanate and perchlorate have to do with any of this? Turns out, thiocyanate and perchlorate are common environmental pollutants that disrupt normal thyroid function. They do so by functioning as competitive inhibitors of iodide uptake at the sodium iodide uptake transporter protein. Let's talk about propranolol. Propranolol is the most common used beta blocker to prevent conversion of thyroid hormones to T3 in the peripheral tissues. It's one of our most effective tools in our toolkit for treatment of thyrotoxicosis, also called thyroid storm or symptomatic hyperthyroidism. It's an excess of thyroid hormones, both production and secretion, produces increased heart rate, tremors, and nervousness. Propranolol is a non-selective beta-1 and beta-2 blocker. It's widely used to reduce heart rate and tremor during thyroid storm because it inhibits conversion of T4 to T3, and it may help reduce systemic vascular resistance. Student doctors, let's talk about drug-induced thyrotoxicosis. In other words, iatrogenic, inadvertent causation of a disease through the use of a drug. Amiodarone can cause type 2 amiodarone-induced thyrotoxicosis. This occurs from actual thyroid tissue destruction, so you need baseline measures of TSH, free T3 and T4, and repeated every 6 to 12 months. If you see hyperthyroidism, this is cause for concern. Amiodarone is a commonly prescribed medication for arrhythmia, both atrial and ventricular arrhythmias. Each tablet contains 74.4 milligrams of iodine, with 7.4 milligrams being released as free iodine. Turns out the daily recommendation of iodine intake is 0.15 milligrams. This is 50-fold higher than humans need in their serum. This results in increased thyroid hormone production and release, amiodarone-induced thyrotoxicosis. This is important because this iatrogenic disease develops in 3% of amiodarone-treated patients, classified as either type 1 or type 2, with type 1 patients having underlying Graves' disease or nodular disease, whereas type 2 results from actual destruction of thyroid tissue, which stimulates the release of preformed thyroid hormones into circulation. Student doctors, let's talk about the Thioamide group of medications. Propothiouracil, PTU, Methimazole, or carbimazole, which is a prodrug that is converted to methimazole. The methimazole is 10 times more potent than PTU. Methimazole is used when the thyroid gland produces excess thyroid hormone, such as occurs in Graves' disease. It blocks iodide organification, has major side effects. You'll also note elevation of serum transaminases, jaundice, hepatitis, necrosis, encephalopathy, and even death. Therapy with Thioamide derivatives should be administered cautiously in patients with pre-existing liver disease, a history of alcohol abuse, or hepatitis. Methimazole is often used before thyroidectomy. It's taken before thyroid surgeries, lowers the thyroid hormone levels, and minimizes the effects of thyroid manipulation. It does so by inhibiting the enzyme thyroperoxidase, which catalyzes a necessary step in the synthesis of T3 and T4. Let's talk about potassium iodide. Potassium iodide is a stable form of iodine. It blocks iodine uptake. It's used as a treatment for hyperthyroidism, used as a treatment for iodine deficiency. Potassium iodide can also be used along with antithyroid medicines such as methimazole to prepare the thyroid gland for surgical removal. Potassium iodide can also be used to protect the thyroid from radiation exposure. It shrinks the thyroid gland and decreases thyroid hormone production, does not affect heart rate, and does not produce an irregular heartbeat. Let's talk about Propothiouracil. Indications for usage: patients with Graves' disease, patients with toxic multinodular goiter, those patients who are intolerant of methimazole. PTU is also used when surgery or radioactive iodine therapy is not an appropriate treatment option. It's used to ameliorate symptoms of hyperthyroidism, used in preparing for thyroidectomy, and also used in radioactive iodine therapy in patients who are intolerant of methimazole. PTU inhibits synthesis of thyroid hormones in hyperthyroidism. It also inhibits the conversion of thyroxine to triiodothyronine in peripheral tissues, but does not inactivate pre-existing T4 and T3, which are stored in the thyroid or circulating in the blood. Moreover, PTU does not interfere with the effectiveness of thyroid hormones given by mouth or injection. It may be an effective treatment for thyroid storm. Student doctors, let's talk about levothyroxine. It's used to treat thyroid hormone deficiency. It's the manufactured form of the thyroid hormone. It's in the form of T4. It's converted to triiodothyronine. Its maximum effect can take up to 6 weeks. Numerous side effects including weight loss, heat intolerance, sweating, anxiety, trouble sleeping, tremor, and fast heart rate. There are numerous drugs on the market that impair levothyroxine absorption, to include antacids, iron, sucralfate, anti-ulcer medications, cholestyramine, orlistat, and proton pump inhibitors. Let's talk about radioactive iodine. It's used as a therapy for thyroid cancer. Because the thyroid gland selectively absorbs iodine, the radioactive iodine destroys the thyroid gland, has little effect on the rest of the body, and it's contraindicated in pregnant women. Okay, student doctors, that's it for drugs to treat thyroid disorders, except for at the end of the PowerPoint or PDF, you'll see a number of practice questions for your perusal. Thank you so much. I'll talk to you guys later.